How about hypersensitivity disorder type 1, type 2? Type 1, we have A, B, C, D, E. A for allergy, chromosome 5. B for bronchial, you know that. C. And then, can you remember C? C for capsulitis, it is withdrawn now, and D for drugs, penicillin. And then, in type 2 disorder, we have my blood group is Rh positive. I think you know that more than sure. And then coming to the immune complex disease, it is in sharp. Okay, yes. Just remember sharp there. Uh, so sharp because it is circulating freely in the circulation, right? So we have to deal with the sharp thing. So that is the sharp is the mnemonic here. S for SLE, serum sickness, Schick test for the corynebacterium diphtheriae, and HSP, Henoch-Schönlein purpura, and most common manifestation in children is vasculitis in children, and IgA, it is the antibody involved, and most common organ is the kidney. Okay, kidney, children, vasculitis is the most common thing, HSP. Okay, IgA. And then coming to the what are the other H's, HB and HC and arthritis. And then coming to the A component is the Arthus reaction. It is the localized Arthus reaction. Then coming to the R for the Raji assay, and P for it is a localized immune complex disease. Okay, what is the Arthus reaction, and R for Raji assay, and P for post streptococcal glomerulonephritis, and pan and parasitic diseases. Most common vasculitis in children is HSP. Most common vasculitis in child with the death associated with the death is Kawasaki disease or maybe coronary disease. Whereas the most common vasculitis in adults is the temporal arteritis or maybe giant cell arteritis. Okay, so just remember sharp. Yes, we will just go from the reverse. PAN post streptococcal glomerulonephritis, and PAN parasitic disease like malaria. It results in membrano glomeruloproliferative disease, and also called as the nephrotic syndrome. R for Raji-assay, A for Arthus reaction or the localized immune complex disease, HSP, Henoch-Schönlein purpura for hepatitis B, hepatitis C for H, and then serum sickness, Schick test, and SLE for yes. Okay, then time for hypersensitivity disorder is in cell mediated disorder. Other thing are T cell mediated. Okay, this is in delayed hypersensitivity disorder, CD4 and CD8, Th1, interferon gamma, granuloma formation is seen here, and okay, and then in all the cells there is an antibody expression is present, but here it is a T cell expression. And as a first exposure, organism itself, major histocompatibility, complex activation, Th1 activation. So we know that Th1 means interleukin 2, NK cell, TNF beta, interferon gamma for granuloma. And what the main typical features of the granuloma and vasculitis, temporal arteritis. Okay, skin test, Montos, lepramin. Remember Monto, lepramin for type 4 hypersensitivity disorder, and contact dermatitis. Worldwide, the most common thing is the poison, IV poison, and in India it is detergent and art, jewelry, artificial jewelry, nickel and cadmium, because it is made up of that. Then coming to the lepra reaction, type 1 and type 2. Type 1 lepra, it is the type for hypersensitivity reaction. Type 2 is the type 3 hypersensitivity reaction. Just remember as addend as 5, 4 plus 1, 5, 3 plus 2, 5. And then coming to the type 5, we already saw that it is myasthenia gravis and Graves disease. Then coming to the concept of the tolerance here. Then coming to the feature of the tolerance here. Tolerance, we have central tolerance and peripheral tolerance. Thymus, bone marrow, central tolerance, deletion and editing happens here, and B cell, T cell, energy T regulatory cell, and apoptosis. And bone marrow, thymus, it is the first mechanism. Central under central tolerance is the deletion or maybe negative selection. Self-reactive T cells, gene AARE, regulator gene. There is when there is a defect, it become this is the formation of autoimmune polyendocrinopathy. So AARE results in AIPE. IRE results in AIPE. Then coming to the receptor editing of self-reactive B cells, and then coming to the energy T cell energy, the second signal. B cell energy, it is also the second signal. Second signal means activated signal. And outside antigen, there is an MHC activation. MHC activation B 7.1, B 7.2. There is a CD28 activation. There is a signal transduction by number 2. This is the first signal. Okay, first signal is with the alpha beta activation that results in the activation of the T cell. And There is also the second signal. It results in the direct activation of the B cell itself. It doesn't need to go through the T cell to B cell. Okay. And then for the self antigen, we have one first signal is even enough, and for second signal won't be present in case of self cell, whereas it both will be present in case of outside cell. That is the difference you have to see. When there is a loss of this signal modification, that is called as an energy. Then coming to the T regulatory cell, it is a subset of the CD4 cell. It's an important few points I'm just going to say from here now. Subset of CD4, CD25 positive, IL2 receptor positive, FOXP3 gene defect. It's called results in IPEX, immune dysregulation, polyendocrinopathy, X-linked disorder, CD4 plus, CD25 plus. Okay. Immune dysregulation, polyendocrinopathy, X-linked disorder, CD4 plus, CD25 plus. CD25 is also can be given in the question as interleukin 2 receptors. And then T regulatory cell, which results in increased expression of CTLA4 PD1 immune expression. Okay, CTLA4 PD1 immune expression, and CD25 positive FOXP3 gene defect results in IPEX, idiopathic polyendocrinopathy, X-linked disorder. Okay, then AARE. Can you remember that AARE results in AIP? That is also the central tolerance mechanism only, but here IPEX is the peripheral tolerance, polyendocrinopathy. Autoimmune polyendocrinopathy for central tolerance disorder, and immune dysregulation, polyendocrinopathy, enteropathy, X-linked disorder for peripheral tolerance. Okay, poly P. Then coming to the T regulatory cell, I already said that CD4 activation, CD25, FOXP3 activation, gene interleukin 2 activation, and third mechanism is the killing of the self-reactive. Third mechanism is the killing of the self-reactive cells B and T cell apoptosis CD95 defect ALPS. Okay, defect ALPS, autoimmune lymphoproliferative disorder for the peripheral tolerance, and cryptic or maybe hidden antigen. It is the BET that becomes during trauma. It becomes exposed, and that results in activation. BET brain eye testis brain antigen brain antigen ophthalmic B and testis antigen, and when there is a defective tolerance, autoimmune disorders comes. So list are SLE type 3, okay, sharp type 3, and then type 2 and type 3 mostly. So type 3 most common. It's a 11 criteria for the present. Diagnosis 4 criteria is enough. Coming to the 3 skin conditions present are butterfly rash, malar rash, discoid rash, the coin like lesions, and photosensitivity. 3 skin condition, and 3 mucosal condition, 3 inflammatory condition, aphthous ulcer, arthritis, serositis, and then 3 organs are involved. Renal lupus nephritis, most common mechanism is the most common morphology is the wire loop lesion can be seen, and lupus cell, LE cell is present here, and blood hematological is the pancytopenic or maybe LE cell is present, and neurological CNS psychosis is the presentation, and last two is the immunological. Immunological most sensitive antibody is the ANA, whereas the most specific is the Smith is specific. Okay, just remember only one line. Smith is specific antibody, both sensitive and specific is the double standard. Neonatal lupus anti-Rho antibody is the specific thing, and for ANA anti-nuclear antibody. Okay, so 3 skin, 3 organs, 3 inflammation, and through antibodies. Drug-induced lupus, ship drugs, sulfonamides, hydrolyzine, isoniazid acid, procainamide, and drugs. Antibody, anti-histone antibody, and Sjogren's syndrome, dry eyes, dry mouth, anti-SSA, Rho most sensitive, La specific. Remember La female name, that's a specific. Smith men name, it is also specific. Okay, and then diagnosis by the lip biopsy, serology, Rho and La, and minor salivary gland. Demonstrated lymphocytes can be demonstrated. It's in previous year question. And coming to the scleroderma, sclerosis, limited skin anti-centromere antibody is present. Centromere center, it's a contradictory, we see present in the peripheral, that is the skin, whereas the diffuse top, but we see it in the whole all over the body. Anti-topomerase antibody, anti-sclerosing 70. Okay, it results in systemic sclerosis. Then coming to the scleroderma, it's limited and diffuse, limited associated with the crest syndrome, calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly. Okay, calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Multiple sclerosis, T cell self-reactive demyelinating disorder, it destroys the myelin of the nerves, and a special thing, Luxal fast in blue. Okay, tryptophan blue for the negative dead cell demonstration. Autoimmune anemia, autoimmune hemolytic anemia, or drug-induced hemolytic anemia, and pernicious anemia. Idiopathic thrombocytopenic purpura, immune complex against RBCs, good pasture syndrome against what is this? Good pasture for the G, my blood group G type 2. Myasthenia gravis, it's what is this? It's a special variant of the type 2. Okay, Graves disease, special variant of the type 2. Then immunodeficiency disorder, primary immunodeficiency disorder, secondary immunodeficiency disorder. Under secondary immunodeficiency disorder, malnutrition is the most common, and HIV/AIDS, cancer, chemotherapy, radiotherapy is present there. And coming to the most common immunodeficiency, primary is the SCID, severe combined immunodeficiency disorder. Rash, mobiliform rash, diaper rash is present. The SCID, autosomal recessive, X-linked, X-linked recessive, autosomal recessive. Two traits are there. In X-linked, we have a gamma subunit of the cytokine receptor defective. So there is no development of the NK cell because interleukin 2, 4, 17, 7, 15 not at all present. So no development of the NK, no development of the T, and immunoglobulin production is also hampered. Mainly T cell not present, NK cell not present. So because of that, the disease is being overfledged. And then coming to the autosomal recessive. So remember AAA. X for gamma, just remember that because we used to write down the same way. ADA deficiency, adenosine deaminase, and which results in deoxyadenosine accumulates, toxic to BTNK. And then first disease to be treated with the gene therapy is the leukemia. Okay, GVHD, poor response iris, and first gene therapy leukemia treatment. And then coming to the first discussed about SCID, we had AR component and maybe the X-linked recessive component, and now we have X-linked recessive, Bruton, hypoglobulin, aglomeraulin, name itself disease. There is no IgG and there is no immunoglobulin specifically. Boys BTK gene, Bruton's gene, pro and pre B cells not is defective here. So there is no formation of the mature, there is no formation of the antibody itself. Okay, then coming to the Dijot syndrome, catch 22, cleft lip, cleft palate, abnormal face is thymic hypoplasia, T cell defect, tetralogy of Fallot, hypocalcemia, deletion 22q12, and velocardia deficiencies and immunodeficiency, and third and fourth pharyngeal pouch, thymus parathyroid gland gone. And combined variable immunodeficiency. Okay, so what is the difference between combined variable immunodeficiency and Bruton's is that the mature B cells are present here, but mature B cells are present here, but it can't produce plasma cells. Okay, because combined variable immunodeficiency, there is an inducible CO stimulator, ICOS, that stimulate T cells, that is also defective. And BAF gene. Okay, so BAF, it results in defective production of this plasma cell, whereas the BTK gene or Bruton gene for this thing. Okay, so second portion of the disorder is also over now.